Imagine going through surgery, something that's meant to make you better, but then ending up with a whole new problem, one that just lingers.
Yeah, we're talking about chronic post-surgical pain or CPSP.
Exactly. And you might be surprised actually at how common it is. We're looking at maybe 10% to even 50% of adults, depending on the specific surgery.
It's a huge number when you think about it. Over 300 million surgeries happen worldwide every single year.
Wow. So even a small fraction developing chronic pain is, well, it's a massive number of people affected.
Absolutely.
So today we're doing a deep dive into this. It's complex, often really frustrating for patients. Our mission is to unpack what CPSP actually is, how we define it now, why it happens.
And crucially, what the latest research and guidelines tell us about preventing it and managing it if it does happen.
Right. We're drawing on recent studies, major clinical practice guidelines, so you get a really solid, well-informed look at this often overlooked issue.
Okay, so let's talk about the scale first. This isn't just a few unlucky people.
No, not at all. When we talk about the scope of chronic post-surgical pain, the numbers, they're kind of staggering, and they point to this hidden public health challenge almost. A procedure meant to heal ends up creating this persistent struggle for potentially millions of people globally every year. It makes you wonder, are we sort of inadvertently creating a silent epidemic here?
And it's not just a number on a page. The impact on people's lives is just profound. This isn't some minor ache.
Right.
It often gets in the way of everyday activities. It can really hit your quality of life hard, emotionally, physically.
Yeah.
Just like the UK, for example. Severe, persistent post-surgical pain affects somewhere between 2% and 10% of adults having surgery. That works out to at least 140,000 people every year dealing with disabling pain.
That's sobering. And our understanding of CPSP, it feels like it's really shifted, hasn't it? How exactly has the definition evolved? What was the old thinking?
That's a really key point. The IASP, that's the International Association for the Study of Pain, they now define it pretty clearly. It's pain that starts or gets worse after surgery. It lasts at least 3 months.
Okay.
It's located around the surgical area, and other causes have been ruled out, things like infection or maybe pain that was already there.
Ah, okay.
Historically, yeah, the assumption often was, oh, it's just acute pain that's sticking around too long.
Right.
But actual studies, they show something different.
Oh.
A good chunk of patients are actually pain-free or maybe just have mild pain right after the operation.
Right.
But then weeks, sometimes even months later, new or different pain sensations pop up.
That's fascinating. So it's not always just a continuation.
Not always, no.
You mentioned ruling out pre-existing pain. That sounds important for getting the diagnosis right. How much does that complicate the picture?
Oh, hugely. Accurately figuring out if the pain was there before surgery is critical. Research really highlights this.
Yeah.
For example, some studies might find CPSP prevalence around, say, 18% if they just look at moderate to severe pain near the surgery site. But if you carefully exclude anyone who had any pain in that area beforehand, that number can drop way down, sometimes as low as 6%.
Wow, quite a difference.
It really is. And it just underlines why we need a thorough assessment. It's not just about how intense the pain is. We also need to look at the distress it causes, how it interferes with function, stuff that's now part of the ICD-11 definition.
That makes sense. It sounds incredibly frustrating, though, especially because this comes from something meant to help.
It absolutely is. I've seen patients who feel completely bewildered almost, like betrayed by the whole process, by their own bodies.
I can imagine.
It's a massive psychological weight, and it often gets missed. Plus, there's this compounding issue where patients with chronic pain sometimes face, well, marginalization from healthcare providers.
Really? Why is that?
It can stem from biases, maybe unmet expectations about how surgery should turn out. And honestly, there's often a gap in medical and nursing education when it comes to spotting and treating CPSP effectively.
So it's a systemic issue, too, not just a physical one. What are some of the big challenges within healthcare itself for tackling CPSP?
Well, a major one is just timing. Often, CPSP isn't really identified until months down the line.
Right.
By then, the brain and nervous system have already started making these complex changes, what we call neuroplastic activity, that are linked to chronic pain. And that makes it much, much harder to treat successfully. So identifying people at risk before surgery and trying to prevent it, that's really essential.
Okay, neuroplastic activity. Are you saying the brain literally sort of rewires itself to keep feeling pain even after the original wound has healed? That sounds kind of alarming.
That's a good way to put it, yes.
Yeah.
It's precisely that. So we've talked about the impact, the scale. The next big question is why? What's actually happening inside us that turns healing into this ongoing struggle? Let's get into the biology.
Okay, let's do it.
To really get CPSP, you first need a basic idea of how acute pain normally works. It's a sequence. Transduction nerve endings get activated by the painful thing.
It's like the surgical cut.
Exactly.
Right.
Then transmission, the signal travels up to the brain. Then modulation, this is where the body normally tries to dial the pain down.
Right, the natural pain relief systems.
Yep. And finally, perception, that's when we consciously feel it as pain.
So in that normal process, where does it go wrong to lead to chronic pain like CPSP?
Well, this is where it gets really interesting. In chronic conditions like CPSP, those pathways become, well, dysfunctional. Things change at several levels.
Okay, like where?
First, in the periphery, right at the surgical site. You get a reduced pain threshold because of inflammation that just doesn't quit.
So the area stays hypersensitive.
Hypersensitive is a good word. Think of inflammatory chemicals swirling around interleukins. Substance P complements C5a, all keeping those nerve endings on high alert. This is peripheral sensitization. Even tiny changes, like a slight drop in pH at the incision, can activate specific pain sensors.
So the local wound environment is basically shouting danger constantly. What about further up the line? You mentioned the spinal cord.
Right, so in the spinal cord, all that constant signaling from the periphery creates hyperexcitability.
Yeah.
It's like, imagine turning up the gain on an amplifier way too high. Receptors that are normally quiet, like NMDA receptors, get activated.
Yeah.
This leads to something called wind-up. Suddenly, things that shouldn't hurt, like a light touch, become intensely painful. That's allodynia.
Okay.
And this whole escalation of nerve activity in the spinal cord, that's a key part of central sensitization.
Central sensitization.
Yeah.
Got it. And the brain, does it get involved too?
Oh, absolutely.
Yeah.
There's a really strong link between chronic pain and changes in mental state. It can mess with coping skills, lead to anxiety, depression.
Yeah.
It's all interconnected.
And maladaptive coping abilities, what does that actually look like for someone? Avoiding moving, pulling back from life.
Exactly that. It might mean someone stops doing things they used to enjoy or they withdraw socially.
Okay.
Sometimes they develop this real fear of movement, which ironically can actually make the pain feel worse. And it goes even deeper. We're now seeing evidence for epigenetic changes.
Epigenetic, like changes to how genes work.
Precisely. Things like modifications to histone proteins or DNA methylation. These can actually alter how genes related to pain are expressed. It's complete stuff.
Wow. Okay, you also mentioned something called latent sensitization. That sounds intriguing. What does that mean?
Yeah, latent sensitization is a really fascinating idea. It suggests that the body's own natural opioid system might sometimes be masking an underlying state of heightened sensitivity.
Masking it.
Yeah. So the injury might seem healed, but this latent potential for pain is still there. And interestingly, it can sometimes be unmasked if someone takes an opioid antagonist drug.
Huh.
The thinking is that maybe some people are just less effective at using their own built-in pain control systems, and that inability might actually predict who's more likely to develop chronic pain.
That's complex. So knowing all this science, can we identify who's most likely to get CPSP? Are there clear risk factors?
Yes. Understanding the risk factors is really key for trying to prevent it. Some things are hard or impossible to change, unfortunately.
Like what?
Well, being female, being younger, obesity, and already having pain before the surgery, even if that pain isn't where the operation will be.
Okay.
And then certain types of surgery just carry a much higher risk. We're talking mastectomy, thoracotomy, that's chest surgery, amputation, certain gallbladder surgeries, kidney removal, heart surgery via the sternum, knee replacements, and some inguinal and pelvic surgeries.
That's quite a list. Now, I heard something about smoking that seemed, well, odd. Almost backwards.
Ah, you mean the smoking paradox. Yes, that's a really curious finding. Obviously, smoking is bad for you, full stop.
Right. Absolutely.
But some studies, particularly in patients having thoracic surgery, found that those who kept smoking after the operation actually had a lower rate of CPSP compared to those who quit around that time.
Seriously, that makes no sense.
It seems counterintuitive, doesn't it? And let me be crystal clear.
Yeah.
This is absolutely not a reason to smoke or keep smoking.
Okay, good.
But it does highlight how incredibly complex these factors are. Maybe it relates to the stress of quitting or some other biochemical interaction we don't fully understand yet. Yeah, it makes you scratch your head.
Definitely. What about using opioids before surgery? Does that play a role?
Yes, that's a big one. Preoperative opioid use is a significant risk factor.
Why is that?
Well, it's a bit chicken and egg. Is it that the opioids themselves somehow prime the system for more pain? Or is it just that people taking opioids beforehand likely already have a significant pain issue? But either way, there's a definite link to a higher chance of getting CPSP. It could be related to something called opioid-induced hyperalgesia, OIH, where opioids ironically make you more sensitive to pain over time.
OIH. Okay. So that pre-op opioid use is something clinicians really need to consider.
Definitely.
All right, so considering all these risks and the underlying science, what can actually be done? What are the leading strategies for prevention and managing CPSP? Is there like a golden window around the surgery?
There absolutely is. That whole period, just before, during, and immediately after surgery, the perioperative period, that's a crucial interventional window.
Okay, so what happens in that window?
A key thing is just optimizing the surgery itself, trying to minimize how much tissue and nerve damage happens.
Makes sense.
This can mean choosing less invasive techniques where possible, like laparoscopy instead of open surgery. That can definitely cut down on chronic pain incidents in many cases.
But you mentioned earlier, sometimes less invasive doesn't automatically mean less chronic pain, like with the hysterectomy example.
That's a really sharp point. It shows it's not just about the size of the cut. While laparoscopic hysterectomy, for instance, usually means less acute pain, it doesn't always seem to change the chronic pain rates as much as you might expect.
So it's more complicated than just less trauma equals less chronic pain.
It seems so. It suggests chronic pain involves mechanisms beyond just the initial injury severity. But specific nerve-preserving techniques can still make a real difference, like avoiding excessive retraction on ribs during thoracotomy, maybe using resection instead.
Okay, so minimizing damage helps. What about actually managing the pain signals during and right after?
Right. That leads us to targeted analgesia and these multimodal approaches. We know that how bad and how long the acute pain lasts right after surgery is a major predictor for developing chronic pain later.
So controlling that initial pain is critical.
Absolutely critical. Using regional anesthesia like nerve blocks with local anesthetics can basically intercept the pain signals before they even reach the spinal cord.
Ah, cutting it off at the source, almost.
Exactly. And studies show this helps reduce the risk of persistent pain after things like breast surgery, thoracotomy, and amputations.
And you mentioned multimodal analgesia. I hear that term a lot. What does it actually involve for a patient?
Yeah, multimodal analgesia is really the cornerstone now, and it's backed by good evidence. The idea is to use a combination of different pain relief methods, different drugs targeting different pain pathways, often alongside non-drug approaches too.
Okay.
The goal is to get better pain relief overall, maybe with fewer side effects than just cranking up one type of drug and often reducing the need for opioids.
So what kinds of things are combined?
Well, the recommendation is to routinely use non-opioid painkillers around the clock. Things like NSAIDs, ibuprofen, naproxen, celecoxib, and acetaminophen, or paracetamol.
Even for just a short time?
Yes, even using them for less than 24 hours, before and after surgery, can make a significant difference in pain levels months later, even up to a year. Using 5-V acetaminophen during the perioperative period has also shown benefits in reducing persistent pain.
It's interesting. What about other common pain meds, like gabapentinoids, gabapentin, pregabalin? They seem common.
They are, yes. Gabapentinoids are often considered part of the multimodal plan, mainly to help reduce how many opioids someone needs.
But do they help with the chronic pain itself?
That's where it gets tricky.
Yeah.
Recent large reviews, meta-analyses, haven't found a meaningful effect on chronic pain compared to placebo. Plus, they come with side effects, dizziness, sedation, even a risk of abuse, so you have to use them cautiously.
Okay. Any other drugs showing promise in this multimodal approach?
Ketamine, actually. Low-dose IV ketamine can be an option, especially for people who are already tolerant to opioids or who don't handle them well.
How does ketamine help?
It seems to decrease the amount of pain medication needed after surgery and might lower the risk of pain becoming persistent. It might even help prevent that opioid-induced hyperalgesia we talked about.
And opioids themselves, where do they fit in?
They definitely still have a place. Opioids remain the go-to for moderate to severe acute pain right after surgery.
But not long-term for chronic pain.
Yeah. Exactly. Long-term use for chronic pain is strongly discouraged. The risks, addiction, tolerance, OIH, just generally outweigh the benefits. The focus in chronic pain should really be on reducing opioid use, not increasing it.
Got it. Are there other medication types used?
Yes, sometimes antidepressants like tricyclics, SSRIs, SNRIs are used. They can have pain-relieving effects on their own, plus they can help with mood, which might make it easier for patients to stick with their overall treatment plan.
Okay.
And don't forget topical things, creams or patches with local anesthetics or distracting agents like capsaicin. They offer localized relief with fewer body-wide side effects.
So lots of medication options. What about strategies that don't involve drugs?
Hugely important. Cognitive behavioral approaches can be really valuable additions. Things like guided imagery, relaxation techniques, even hypnosis, or just listening to music.
How effective are those?
Studies show they can have positive effects on pain levels after surgery, reduce the need for painkillers, and lower anxiety. They're safe, non-invasive. And interestingly, teaching patients these techniques before surgery seems to make them even more effective afterwards.
That makes sense. Being prepared. Anything else non-drug?
Tenesity's machines, transcutaneous electrical nerve stimulation. They could be a helpful part of the mix, possibly cutting down on how much pain medication is needed.
And if the pain is really, really stubborn, are there more intensive options?
Yes. For pain that just isn't responding well, more advanced interventions might be considered. Things like nerve blocks, injecting long-acting anesthetics like bupivacaine, or sometimes even botulinum toxin.
Botox for pain.
It can sometimes help with certain types of nerve pain, yes. And then there are nerve ablation techniques like radiofrequency ablation, which basically uses heat to interrupt signals from a specific damaged nerve or neuroma.
Okay, so it's clear this takes a really comprehensive, holistic approach. How do hospitals or clinics actually make sure this happens? What does a good, coordinated strategy look like on the ground?
That's the implementation challenge, isn't it? Ideally, healthcare facilities need clear policies, a solid organizational structure dedicated to safe and effective pain control. This usually means involving interdisciplinary teams, doctors, nurses, physical therapists, psychologists.
A team effort.
Absolutely. And having easy access to pain specialists is vital, especially for complex cases, patients whose pain isn't well controlled, people already on high doses of opioids, or those with a history of substance abuse.
And you wouldn't withhold pain relief just because someone has a history of addiction.
No, that's a crucial point. Adequate pain treatment should not be withheld due to fear of worsening addiction. It requires careful management, often with specialist input, but denying pain relief isn't the answer.
That's really important. Okay, finally, what about us? What role does patient education play in all this? How can listeners be better advocates for their own care?
Patient education is absolutely paramount. It means getting information that's tailored to you, understanding your treatment options, having realistic goals for pain control, knowing how your pain will be assessed.
And this should cover after discharge, too.
Definitely. Good post-discharge planning is essential. That means clear instructions on how to use medication safely, how to manage potential side effects, and this is really key, a clear plan for tapering off pain medications, especially opioids, as the pain gets better.
Right, not just stopping abruptly.
Exactly. For instance, if someone's been on opioids for more than a week or two, a gradual reduction, maybe 20–25% every day or two if the pain is improving, is often a safe way to come off them. It needs to be part of the plan from the start.
So wrapping this all up, what's the big picture here? We've covered a lot.
Yeah, we have.
Yeah.
I think the main thing is that chronic post-surgical pain is, well, it's a bigger deal than many people realize. It's common. It can happen even when the surgery itself was technically a success.
Right, that's the surprising part.
And it's rooted in these really complex ways our bodies process and even remember pain. It's influenced by everything from our genes and mental state to the actual surgical techniques used.
But there's good news too, right?
Definitely. Our understanding is moving forward really fast. We're seeing this big shift towards being proactive, using personalized multimodal strategies.
From planning before surgery.
Through better surgical and anesthetic techniques, better education, all the way to really comprehensive care after you go home. It's transforming how we can prevent and manage it. It really is a team effort, and you, the patient, are right at the center of that team.
That's a positive note to end on. But maybe one last thought to leave people with. Considering how deeply CPSP can affect someone's life, and how complex we now know its origins are, how could we, maybe as a whole society, rethink that entire patient journey? You know, from the very moment surgery is even discussed, all the way through long-term recovery. How do we make sure comprehensive pain management is always treated as absolutely central, not just some kind of add-on or afterthought?
That's a really powerful question, making it a true pillar of care.
Yeah, something to definitely mull over.